Secondary, it's the irradiation to the back. And the third usual complaints of the patient is the development of the belt-like pains. It's the typical for the acute pancreatitis and pancreatitis. The next step is acute pancreatitis, acute abortive pancreatitis. There are two principal ways according to this step of the pathological process. Firstly, it's normalization of the clinical features, decrease the pain, decrease the edema, and absence of the clinical features finally. The second way is the transformation of the acute abortive pancreatitis to the sterile pancreatitis. Sterile pancreatitis. And the final step is the formation of the purulent complications of the sterile pancreatitis. So what's about the clinical steps of the clinical process? The first step is the step or stages. The first stage of acute pancreatitis is the stage of the pancreatogenic shock. Development of the pancreatogenic shock. The usual duration nearly 1 day, 24 hours. It's very individual. But I would like to explain the usual median duration of these stages. The second stage. The second stage is the stage of the polygenic insufficiency. Insufficiency of the liver, insufficiency of the kidneys, insufficiency of the heart, lungs, and other main symptoms of our body. And the final duration of the second stage, 2 weeks. 2 weeks. And the final stage is the stage of the purulent complications. And usually this stage is the reason for formation of the reasons for development of the pancreatitis. I mean formation of the pancreatic cysts and pancreatic fistulas. Now some words about the clinical features and explaining of the multiple vomiting and explaining about the transformation of the sterile process to the purulent process and formation of the cysts and fistulas. How it's possible that the starting of the purulent process without any ruptures, without any traumas of the duodenum, without surgical procedures. It's very important because the last variant of the treatment was the opening of the abdominal cavity and opening of the rectoperitoneal space. The name of this procedure is the abdominalization. This type of operation leads to very fast dissemination of the bacteria, microbes, and formation of the purulent complications. The new tactic of the for acute pancreatitis is the full absence of any types of the operations and non-invasive too before the development of the purulent complications. Very important. Except 2 indications. The first indication is the blockage of the terminal part of the Wirsum duct in case of the gallstone disease, in case of the mechanical jaundice. Is the blockage by the stone. In this situation, we need to fulfill the acute non-invasive operation, endoscopical retrograde papilla sphincterotomy. We need to dissect the papilla artery for preventing very serious problems. In case of any impossibilities of the endoscopical treatment, we can use the traditional method is the transduodenal papillary sphincter. After laparoscopic incision, we can dissect the wall of the duodenum, and after that we can perform the dissection of the papilla vater. Which reasons lead to development of the laparoscopic operation? It's some types of the previous operations. For example, beer resection sometimes is the indication for transduodenal papillary sphincter. The next indication for the acute operation on time of the sterile pancreatitis is the development of the urinary peritonitis. It's the urgent indication for development of the laparoscopic operation, sometimes laparatomic, very rare, and cleaning the abdominal cavity, draining and cleaning of the abdominal cavity. Only two indications for the surgical procedures, no other indications. Now, some words about the reasons for development of the pulmonary complications, how it's possible. I told you about the multiple vomiting, the main sign of pancreatitis and pancreatitis. The reason of this complaint of pathological process is the starting of the high intestinal obstruction. What I mean, it's the starting of the functional development of the functional intestinal obstruction. The level of this obstruction is the duodenum. Total is the stop of the peristalsis in the duodenum. And the result of this is it's a very high obstruction and multiple vomiting. Finally, non-effective vomiting. The presence of a lot of bacteria and absence of the peristalsis lead to very good temperature, a lot of food for bacteria. They lead to very serious spreading of the bacteria, and the absence of the peristalsis lead to abnormal walk, abnormal situation in the wall of the duodenum. And long time process, I told about the duration of this period, 2 weeks. After 2 weeks, we can see the translocation of the bacteria from the lumen of the duodenum to the retroperitoneal space. Now some words about the anatomy. Firstly, the small video about the anatomy, and after that, my explaining about the types of the organs according to the peritoneum, and the information about the main tissue of the retroperitoneal space.
The abdomen. It rests
Can you hear the sound of the video?
Yes, sir.
Okay.
against the backbone in front of two major blood vessels called the aorta and the inferior vena cava. It is also covered by the stomach and the liver. The pancreas is divided into 3 anatomical portions: the head.
Sometimes not only the 3, sometimes we can differentiate the 4 parts. It's the head, neck, body, and the tail.
Body and tail. The head of the pancreas is surrounded by the duodenum, the part of the intestine that connects the stomach to the small bowel. The tail of the pancreas resides in the hilum of the spleen.
A very interesting fact according to the investigation. The presence of the pathological process, the presence of the necrosis in the tail of the pancreas lead to presence of the fluid near the upper part of the left kidney.
The pancreas has two very important functions. Most of the gland is involved in producing the digestive enzymes that are collected in the main pancreatic duct and then emptied into the duodenum. These enzymes are involved in the digestion of fats, sugars, and proteins. There are also small microscopic groups of cells dispersed throughout the pancreas called the islets of Langerhans. These small groups of cells produce a variety of hormones, including insulin, that are released directly into the blood and help regulate a variety of different functions, the most important of which is keeping the blood sugar, or glucose, in a normal range. Glucose is the main source of energy for the body. A variety of benign and malignant tumors can arise in the pancreas, often in the head of the gland. Tumors in this area present a particular problem because the head of the pancreas is at an important crossroads where the pancreatic duct empties its digestive enzymes into the duodenum and the bile duct
Location of the pancreas. It's very important situation according to the development of the acute and chronic pancreatitis. Pancreas is the retroperitoneal organ. All parts of this organ are located in the retroperitoneal space. There are three typical types of the locations according to peritoneum. We need to differentiate two principal types: is the parietal and visceral peritoneum. The first usual type is the intraperitoneal organs, for example, stomach. The second type is the mesoperitoneal organ. The usual example is the duodenum. Duodenum. For example, descending and ascending type of the large bowel, principally mesoperitoneal cavern is the cavern only of the one part of the earth. According to the duodenum, is the covering by the parietal peritoneum only of the first resulting part of the duodenum, and other parts covered is not total covering by the peritoneum. And the final part of the duodenum, vertical and lower horizontal part of the duodenum, are localized in the retroperitoneal space. This location, it's very important according to the development of the urinary complications. Translocation of the bacteria through the normal, not the normal, without ruptures. The wall without ruptures lead to spreading of the infection to the main tissue of the retroperitoneal space. It's the fat tissue. And result of this is very fast spreading of the process in the retroperitoneal space with the development of the, firstly, parapancreatic abscesses. It's not the abscesses of the pancreas, because the size of the pancreas is not critical. parapancreatic abscesses, and development of the retroperitoneal phlegmodes, left or right retroperitoneal phlegmodes, and sometimes the total phlegmodes of the retroperitoneal space. The level of these phlegmodes from the level of the diaphragm and the lower part near the bones, spina iliaca, posterior superior. The volume of the phlegmones is very, very dangerous, very big and dangerous for the patient. Now, the main etiological reasons for development of the acute pancreatitis, for abortive pancreatitis, and for development of the recurrent cases of the chronic pancreatitis. We need to differentiate two principal types of the factors or reasons. Not important. It's the primary and secondary reasons. Primary reasons is the reasons in the pancreas usually, and the secondary reasons are localized near the pancreas, far away from the pancreas. The usual and the main reason for the primary reason for development of the acute pancreatitis and for development of the recurrent case of chronic pancreatitis, it's the alcohol. The usual answer of the students is the alcohol intoxication. The students not. It's not the intoxication. The main mechanism for development of the relapsing case or development of the first time of pancreatitis, it's a very serious stimulation the production of the pancreatic juice. Production of the pancreatic juice in the pancreas. The main problem of the pancreas, according to the development of the pancreatitis, any types of the pancreatitis, it's the high pressure in the diameter, in the lumen of the pancreatic duct. Some words about the sizes, normal sizes of the pancreas. By the ultrasound, we can examine not the vertical part, it's like the horizontal part of the pancreas, like this, according to the perpendicular projection of the ultrasound investigation. Because the vertical projection is not the this projection of the pancreas is not the wing, not with this size of the head, the normal maximal size, near the 32 millimeters. The middle size, maybe we can find more smaller size for the small valves, but middle size, 3 centimeters. The middle size of the body, 2 centimeters, and 2.5 centimeters for the tail of the pancreas. Two main ducts of the pancreas. The first main pancreatic duct. The Latin name of this duct is the Wirsung duct. Wirsung duct. Wirsung. Wirsung duct. The maximal diameter of the Wirsung duct 3 millimeters. Increase the diameter more than 3 millimeters. It's the indication, is the information about the presence of the pancreatic hypertension. And you need to know about the secondary or additional pancreatic duct. The name of this duct is the Santorini duct. Usually you can find this duct in the normal situation without the presence of the hypertension. By the using of the geometry, we can find the total volume of the main pancreatic duct. The usual length of the pancreas near the 22 centimeters length of the pancreas, And in case of the maximal diameter 3 millimeters, the total volume will be 1.5 milliliter, 1.5 milliliter volume. And all reasons with increase of the intraluminal pressure lead to development of the process like the reflux in the venous system. Reflux into the intercellular space from the connections with the main pancreatic duct and additional pancreatic ducts. We can see reflux of the pancreatic juice to the intercellular space. We can find this process in case of the alcohol intoxication and according other reasons. I will explain this later. Alcohol plus usually the fatty food is the usual process, the drinking of the alcohol and eating of the fatty food lead to activization, production a lot of pancreatic juice, reflux, and finally it's the presence of the pancreatic juice in the intercellular space with the development of the autolysis, the process of the autolysis. It's the presence and the starting of the auto digestion of the pancreatic cells. Pancreatic cells. The next reason, primary reason, it's the endoscopical or postoperative pancreatitis. Postoperative pancreatitis. According to this reason, I need to explain any types of the activations with the increase of the intrapancreatic pressure. And the main examples, it's any operations on the pancreas, any variants of the resection, any variants for development of the anastomosis, any operations near the pancreas, for example, operations on the spleen, for example, removing of the spleen, splenectomy, or development of the gastrectomy, of the partial gastrectomy, or resection of the stomach. All types of the operations, and finally the simple compression by the finger of the doctor or by the instruments lead to development, sometimes without the presence of the preoperative treatment, lead to development of the acute pancreatitis. The next reason is the endoscopical procedures on the bile ducts and pancreatic ducts. The traditional and usual procedure for the treatment of the biliary ducts, for investigation of the pancreatic ducts, visualization of the bile ducts, it's the ERCP, endoscopic retrograde pancreatic cholangiography. Principally, there are two stages in this method of investigation. Firstly, the introduction of a special flexible device and the duodenoscope in the duodenum with the finding of the papilla artery and cannulation of the papilla artery and injection of the contrast means. I told you about the total volume of the main pancreatic ducts. It's only the volume less 2 milliliters, and injection of the contrast means in the system of the biliary ducts and pancreatic ducts lead to very high increase of the intrapancreatic pressure. We must know about the selective type of investigation. According to the selective type, we can insert the catheter for injection only for the biliary ducts or only for the pancreatic ducts. We can control the volume of the contrast means. We can prevent the development of the acute pancreatitis by the use of the smallest volume of the fluid injection. The secondary reason for development of acute pancreatitis is the characteristic of the fluid. The iodine contrast means it's very aggressive fluid. It's not the water. Okay, usually we can use the 50% solution of this contrast meals. Very aggressive. It's the secondary effect for development of acute pancreatitis. It's the chemical process by the chemical burning of the pancreatic ducts. Abdominal trauma, the next main reason. We need to differentiate principally two types of the abdominal trauma. The first type is the blunt traumas, and the second is the penetrating trauma. Penetrating trauma with the damage of the lumen of the main pancreatic duct is the usual factor for development of the internal fistulas, internal pancreatic fistulas. And the first place will be the stop of the bleedings. No, and secondly, the development of the pancreatitis too. But the blunt traumas, without the rupture, without the damage, the capsule of the pancreas, it's the possible reason for development of the typical development of acute pancreatitis. For example, the road incidence with the development of the blunt trauma is the real reason for development of the pancreatitis and maybe pancreonecrosis too. Secondary reasons. The main reason is the gallstone disease. The traveling of the stone through the cystic duct to the common biliary duct and finally to the papilla vatery. Look at this, in the final part of the papilla vatery with the blockage of the papilla vatery, but without the disconnection of the pancreatic duct and main pancreatic duct and common biliary duct. Occlusion, blockage of the terminal part lead to development of the theory of general channel. What is this? It's the formation of the union hydraulic system of the biliary ducts and pancreatic ducts. And it's very terrible for the pancreas. Why? The usual production of the pancreatic juice per day near the 800 milliliters. And after the obstruction, we can see very fast decrease the production of the pancreatic juice and decrease the production of the bile. But the production of the bile, producing of the bile by the liver near the 2 liters per day. And the pressure in the biliary system more higher than the pressure in the pancreatic system. And we can see reflux of the bile to the pancreatic duct, and without the reflux, the high pressure leads to reflux of the pancreatic juice. With the development of the very classic picture of the acute pancreatitis and pancreonecrosis. Some words about the treatment, about the strategy of the treatment. The patient with the acute pancreonecrosis. I told about the only 2 indications, and principally the patients with the acute pancreatitis, acute pancreonecrosis, patients according to the first and second stage, according to polygenic insufficiency and pancreatogenic shock, with the patients not for the surgical department. It's the patients for department of the reanimatology. It's the reanimatological patients. And we need to know some seldom factors. It's the secondary factors, but not very frequent, not very important. Is the presence of the sometimes of the endocrinal disease, pregnancy, some types of the poisons or drugs or narcotics lead to development of the primary pancreatitis. Immune and allergological factors all possible in our life, but the statistic according these factors to neurogenic pancreatitis, congenital pancreatitis. Congenital pancreatitis usually is the childhood problem for the childhood surgery, but sometimes we can find these patients, and the main problem is the process like the acute sclerotic cholangitis. It's the sclerosis of the pancreatic duct, congenital sclerosis with any problems for outflow of the pancreatic juice. Viral and parasitogenic pancreatitis. Sometimes the blockage of the papilloartery by the asteridosis is the real reason for development of the acute pancreatitis too. Some words about the gallstone disease. Gallstone disease and anatomy. Anatomy of the common biliary duct. So there are four main parts of the common biliary duct, but the pre-final and final parts of the common biliary duct is very important according to the development of the acute pancreatitis and more for the chronic pancreatitis. I mean the presence of the big stones, in the common biliary duct. It's a possible situation without the development of the cholangitis. It's a long time process, and the presence of the stones here, it's a real reason for compression of the main pancreatic duct. This anatomical picture on your screens, it's the usual for the 75% of the population. You need to remember about the presence for the 25% of the population, presence of the papillominor. Usually we can find only papilla major, papilloartery, but we need to remember about the possible presence of the one more way for evacuation, for removing of the not removing, evacuation of the pancreatic juice to the duodenum. And for this 25% of the population, the blockage of the biliary system is not very difficult. Yeah. Так, ну, пожалуйста, some classifications. The main morphological forms of chronic pancreatitis, it's the development of the chronic indurated pancreatitis, chronic pseudocyst pancreatitis, chronic pseudocalculose pancreatitis. Please put down this classification in your notes. Clinical forms of chronic pancreatitis: chronic relapsing pancreatitis, chronic painful pancreatitis, latent pancreatitis, pseudotumorous pancreatitis, and chronic cholecystopancreatitis. 5 main clinical forms of chronic pancreatitis. Specific complications of chronic pancreatitis. The presence of the pancreatitis. And now some words about the stones in the lumen of the pancreatic ducts. The basic material for development of the gallstones is the biliary acids, the concentration of the biliary acids. In case of the chronic pancreatitis, it's the transformation and process of the precipitation the proteins in the pancreatic juice. Pancreatic juice is the fluid with the presence of the water. The water is the main component of this juice, and with a very high concentration of the proteins. Proteins, I mean any variants of the ferments, amylase, lipase, and some other ferments. Precipitation usually is the process like the coagulation of the protein, sorry, and formation of this formation of the material object like the stone, plus the process of the calcification lead to formation of the real stones, very strong stones with a very big diameter. I will demonstrate the video with the presence of the stones near the 1.5 centimeter. 1.5 centimeter is not a joke. Так, methods of investigation. Methods of investigation. Firstly, some words about the laboratory investigation. I told you that the first two steps of the acute pancreatitis, it's the process, in the reanimation, not in the surgical department, and we can use the some system for the finding the diagnosis and for the finding the risk of the death and development of any complications. For example, the level of the leukocytosis more than 16,000 is the indication for diagnosis of the pancreonecrosis, not the pancreatitis. It's a very important method for differentiating the acute abortive pancreatitis and development of the pancreonecrosis. For example, age more than 65 years is the one more point for development of the pancreonecrosis too. Usually we can find the changes in the red blood, maybe only small anemia. In the white blood we can find the shift to the left, and for the pancreonecrosis, the level more than 16,000, for the acute abortive pancreatitis less than 16,000. We need to examine the level of the lipase, amylase, C-reactive proteins, and other main laboratory investigation for detection of the inflammatory process. In case of the typical chronic pancreatitis, we need to examine the level of the amylase, because I need to repeat, we need to differentiate principally two main problems in case of the chronic pancreatitis. I mean the remission stage. It's the endocrinal insufficiency and exocrine insufficiency. In case of the endocrine insufficiency, it's the development of the diabetes mellitus and the high level of the glucose, more than 5.5 millimoles per liter in the Russian months. But we need to remember about the possibilities for the development of the diabetes mellitus, the first type of the diabetes mellitus. And in case of the chronic pancreatitis, in case of the chronic pancreatitis, we can find the exocrine problems. Clinically, it's the development of the unstoppable DRS, it's the malabsorption, and some other difficult problems with the nutrition and the problem with the stool. Instrumental investigation. The main method for instrumental investigation is the ultrasound, the basic scanning method for detection of the main problems of the pancreas. And I would like to demonstrate a small video about the use of the ultrasound investigation.
The pancreas to see an atrophic pancreas organ with calcifications. These are typical hyperechogenic reflexes we can find in all of the pancreas organ depending upon severity of the disease. We can also see a dilated pancreas duct due to the intraluminal pancreatic stones or fibrotic changes that have obstructed the duct. In ultrasound image, we can see a dilated pancreas duct here.
I need to repeat, the maximum normal diameter of the pancreatic ducts is 3 millimeters.
Due to a pancreas stone occluding the lumen here, we see fibrotic changes and small and larger echogenic reflexes as a result of the pancreas tissue calcifications. Look at these organ changes that are typical for chronic pancreatitis. In this video, we can see the extremely dilated pancreas duct with multiple.
Так, some words about the symptomatic and visualization of the stones in the pancreatic ducts. The usual color of the stones is white, and the main ultrasound sign of the stones is the distal acoustic shadowing. Because the material of the stones after the calcification is the full block for the ultrasound waves, and absence of the pitch behind the stone, it's presence of the black shadow, presence of the black color behind the stone. It's the information about the absence of the information, absence of the reflection. No reflection, no information, without the black color.
Intraluminal stones. We can also see that the pancreas body itself is atrophic, which is seen best when we go in the cross.
Here we can see the longitudinal projection. Longitudinal is the head, here the body of the pancreas.
Section like this. And the organ itself is composed of almost.
One more picture about the pancreas. The first main information is the size. I need to repeat. The size of the head more than 3 centimeters is the information about any pathological process. Pancreas is two very difficult organ according to the development of the malignant diagnosis. It's very difficult to find the diagnosis of the tumors. Sometimes we can find the final diagnosis, final histological diagnosis of the malignant process only after removing of the pancreas. It's too very difficult to differentiate by the ultrasound, by the CT, MRI, and other distant methods for investigation. And some types of the operation, which is the next step of our lecture, some types of the operations is operations not only for the chronic pancreatitis. There are two principal ideas. It's the variant for the treatment of the malignant process and method for the treatment of the chronic pancreatitis. What we can find in this picture, we can find irregular border of the pancreas. The irregular border of the pancreas is more typical for the pancreonecrosis. We can find the difference between the echogenic. Echogenic is the different colors. White color, it's the increase of the echogenic. Black color, low, it's the decrease of the echogenic. My dear students, how we can find the normal level of the echogenic? Very interesting question. We need to use the parenchyma of the liver for the finding of the medial or normal echogenic. And we can explain the decrease or increase according to the echogenicity of the liver. Except the cirrhosis, except the situations with the fatty transformation, the parenchyma of the liver. It's special for the ultrasonography, but you need to know the principles of the ultrasound investigation of the pancreas and other organs. And here we can see the white objects, usually the calcification, and some black objects. That the next picture. I told you about the I need to increase so I told you about the possible big diameters of the pancreatic gaps. Look at this. It's 11 millimeters. 11 millimeters, and finally we can see the presence of the white object. I need to repeat, the white object usually is the stone. You can see irregular border. Irregular border, the main pancreatic duct. Well, and according to our next lecture is the presence of the shadow of the cyst, post-pancreatic cyst. The next picture. Next very interesting picture, it's the multiple calcification the head of the pancreas. And according to this picture, we need to differentiate principal difference between the calcifications and stones of the pancreas. But the next picture, it's the presence. Yes, I need to decrease in size. Like in case of the previous video, we can see the white objects, two white objects with the black shadow. It's the intraluminal stones in the lumen of the main pancreatic duct with the presence of the shadow. Absence of the shadow according to this high echogenic object, white object, it's the information about the calcification. Usually that's the diameter of the calcification is 2-3 millimeters, usually not more. After these sizes of 3 millimeters, we can find the starting the finding of the distal acoustic shadow. One more time. No distal acoustic shadow, it's the calcification. Presence of the acoustic shadow, it's the stone. ERCP. No, usually we can use this method not in acute process, not on time of the acute process. We can use this method for detection in the remission stage. For example, here we can see it's the ERCP, endoscopic retrograde pancreatic cholangiography. We can see abnormal form of the main pancreatic ducts, presence of these features. And main result of this investigation is the finding of the stone in the distal part, not maybe like here, but maybe like here, the presence of the same stone. This is by the ultrasound investigation, and this is by the X-ray investigation. Presence of the stone. The presence of the stone lead to hypertension, lead to increase the pressure. The next step of our lecture is the explaining of the surgical operations and tactic of the surgical treatment. Так, what is the main idea for the surgical treatment, my dear students? It's the reducing of the pain syndrome, because the pain syndrome is the indication, it's the main indication for the surgical procedures. Not the complaints, it's the, not the complications, it's the main reason is the complaints of the patients, with the development of the terrible pain syndrome, development of the low weight and development of the real potent asphyxia. Because in the on the final stages, the swallowing of the pure water, not the alcohol, not the milk, not the eating of the fatty food, the swallowing, the drinking of the pure water lead to increase of the pain syndrome and development of the chronic pancreatitis, relapsing cases of the chronic pancreatitis. And the quality of the life of these patients is too very low. The second indication is the management of the pancreatic complications and preservation of the pancreatic function. But the main idea of all of the surgical methods is the decompression of the pancreatic system. Without the decompression, no possibilities to normalization of the pathological process. Так. And now we need to differentiate the types of the operations according to the mechanism of the treatment. First step is the operations on the adjoining organs, operations on the biliary ducts and papilla water. And I need to repeat this picture. Without the treatment of some problems of the common biliary duct and papilla water, for example, is the presence of the strictures of the papilla water, it's the presence of the diverticulosis of the papilla water, presence of the adenomas of the papilla water, presence of the ascaridosis of the papilla water. No real possibilities for to reducing of the relapsing case of chronic pancreatitis. Operations on the digestive organs, for example, is the treatment of the duodenum, the treatment of the duodenostasis, development of the abnormal evacuation of the pancreatic juice from the pancreas. It's the one more reason for pancreatic reflux and development of the serious clinical picture. The second type, it's the direct surgical procedures on the pancreas. It's any variance of the pancreatic resections. The next, internal drain procedures on the pancreatic ducts and cysts. I will demonstrate the ideas of this treatment on time our next lesson, on time explaining the treatment of the cysts. Pancreatic duct occlusion, one more very important and non-invasive method of the treatment with the reducing of the exocrimal function of the pancreas. The next, external drain procedures of the pancreatic ducts and cysts. Usually it's the non-invasive procedure by the ultrasound control, for the some countries by the CT scan control. The next, number 3, it's the palliative operations, surgical procedures on the nervous system. It's the some variants of the vagotomy. Today it's not very popular procedure. The next, cryo-destroying of the pancreas. The next, endoscopic procedures on the pancreas and biliary ducts. It's the use of the mother-baby endoscope and endoscopical operations in the lumen of the pancreatic ducts, with the dissection of the strictures, removing of the stones, and some other operations. And the next close surgical operations by the use of the ultrasound or CT scan control. Surgical treatment. Today, the basic operation for removing of the head of the pancreas is the pancreatic duodenal resection or the Whipple procedure, Whipple operation or Whipple procedure. And now I'd like to demonstrate the principal facts about this type of the treatment.
Discussed the Whipple procedure or pancreaticoduodenectomy. It's a very complex procedure, and that is because we need to take the head of the pancreas out, and the head of the pancreas has a very intrinsic relation with the intestine, or the first part that we call duodenum, as well as with the bile duct. The bile duct is really a pipe system that brings the bile that's produced on the liver into the intestine. Now, commonly, a tumor located on the head of the pancreas.
I need to repeat. This is explaining about the tumor. It's about the treatment of the malignant process. But the Whipple procedure we can use for the treatment not only of the tumors. We can treat the chronic pancreatitis too.
Will obstruct this pipe system or bile duct. And when an obstruction of the bile duct occurs, the bile gets backed up into the liver and reabsorbed in the blood, and therefore you develop jaundice.
You can find the same clinical picture in case of the chronic pancreatitis with the edema, calcification, and blockage of the pancreatic ducts and bile ducts too.
The yellow color of the skin, and at the same time,
with the development of the mechanical jaundice,
the stool color can become clay color because now the bile, that's the one that's responsible for the color on the stool, does not get into the intestine, and therefore the stool again turns white. Now, besides taking the head of the pancreas and the intestine and this portion of the bile duct, we need to take the gallbladder out. The reason for taking the gallbladder out is because the duodenum produces some hormones that help the gallbladder to function. Once we take the duodenum out, those hormones are not present any longer, and therefore the gallbladder doesn't function normally. At the same time, taking all of this out may impair the blood supply of the gallbladder, and therefore the gallbladder again has the risk of not receiving adequate blood supply and be ill.
And one more problem is the possible development of the acute cholecystitis and indication for the radical removing of this organ after very big operations with the possible adhesions of some organs with the presence of the strangulation. It's really the sometimes it's very serious problem, and we need to remove the gallbladder for preventing the formation of the stones, for preventing the complications of the gallstone disease, and for preventing the problems sometime of the future operations.
The gallbladder is taken out at the same time of the surgery and really doesn't have any more consequences on the patient than all the rest that we have taken out. The reconstruction is done by putting all of this back together. If we divided the pancreas here and we call this A, and we divided the bile duct and we call B, and we divided the intestine and we call C, if we take all of this out, we're going to end with this situation. The intestine is called C, the pancreas is called A, and the bile duct is B. We took this whole center part. We also divided the stomach past the area of the valve of the stomach at the first portion of the duodenum, and here we call D. This is usually helpful to be able to preserve the whole stomach. In some cases, we cannot do that because of the location of the tumor, and we need to take a part of the stomach along with the rest of the specimen. But in the majority of the patients, we're able to preserve the whole stomach. How do we reconstruct that? The intestine is the part that's movable. Therefore, we flip the intestine to approximate it to the pancreas and the bile duct. In this other drawing, we have flipped the intestine, the end that we had called C now is located here. We connect it to the pancreas, and therefore the pancreatic juices are emptied back into the intestine again. The bile duct is reconnected to the intestine a little further down the stream, and again now bile is able to empty back into the intestine. Further down the stream, we reconnect now the stomach to the intestine, and that is how food gets back into the alimentary system. Then the end result is, one more time, the food goes into the stomach, back into the intestine, pancreatic juice and bile get into the intestine here, and all get together, and you go back to have a normal absorption.
Так, my dear students, today that's all. We should talking about the next types of the surgical treatment on our next lecture. Do you have any questions according this lecture? If not, goodbye and good luck.